slide into the patient's regular day that aren't obtrusive to them. And they don't need to remember, oh, I have to go onto the app and enter my weight now. That is everything we rely on for human memory is a potential for sliding back. And so if we can make it easy and we can make it unobtrusive and we can make it something that the patient sees value for, right? That is how we can really do well.
So Dr. Smith, you had touched upon when a person who has pre-diabetes and then suddenly the onset of type 2 diabetes happens, there is this window of opportunity where the action can be, very vigorous. So we have this golden opportunity to take action, and there's a lot of, emotional draining that happens once type 2 diabetes happens. There's a lot of physical physically it becomes more of a sickness once type 2 diabetes happens, and people get drained in terms of their energy levels. There's a high risk of infection, and financially, again, their copays start to increase. So what is it that we can do in that period to help with this so-called diabetes reversal? And what would be the next steps that you would advise in that regards?
Yeah, great discussion point there. Let me start by going back a little bit in that to say, well, we've seen the incidence of diabetes go up and up and up. And why is that? Well, I think there's a lot of factors to that. I think we are getting better at diagnosing it. I think we're diagnosing it earlier. We've created these new diagnoses, they've been around for a while, but pre-diabetes and metabolic syndrome and all of that sort of thing, really to try to just what you're talking about, get to these folks earlier so that we can help them really understand the process. And I used to write out a graph. I was a very visual teacher for people. You write a graph and you say, here's your blood sugars. They just are slowly elevating over time. Before we didn't see it until they got to here. Well, now we're seeing it way back here. And so, as you said, I'll say to someone who's there for their annual physical, who maybe sees me once a year, maybe even less than that, once every 2 or 3 years, and I see them have a fasting blood sugar of 110, 112, I'm like, okay, guess what? We're going to start seeing each other every 3 months now, and they're like, what? And I said, well, hold on. We want labs every 3 months. We want to check your blood sugars every 3 months and A1C, see where you're trending. You want to check in with me virtually every 6 months, maybe. We come up with a plan that's suitable to them. But the point is, we have work to do. And I tell them, you're going to get some homework assignments here, okay? Here's some really good websites that I want you to look at. American Diabetic Association. I want you to look at the Endocrinology Society websites, mayoclinic.com. Sorry, I don't mean to. If that's bad, we can edit that out. I'll start over and not include mayoclinic.com. But, so let's go back. That we have a lot of work to do with education, and I try to get them to some good quality websites, and I try to educate them about what's happening to their bodies. And that is something that, so I put a lot of that on them, but also we want to try to get them in to the system a little bit more, to what we talked about before. Let's have you meet with a dietitian. Now, the dietitian can spend an hour with you. I got 15 minutes to cover all this stuff. And oftentimes they'll go, oh yeah, that sounds great. That's something we probably should have done a while ago. I'm going to bring my husband with me. So, then we get them in for a dietitian visit, right? And then we get them hooked up with some other resources. We offer them mental well-being. Now, this is kind of a pie in the sky idea, but then we hook them up with, if there's an app for either the health system I'm working at or external apps that are really good at this. We may know one. And we try to help them to understand what's going on, because to your point, and then we decide, how do we monitor them? We teach them how to check their blood sugars with the finger sticks if we don't need to do it all that often. it's hard to go right to a continuous glucose monitor when they're pre-diabetic, so we usually don't do that, but we will encourage them to check their blood sugars here and there, before meals, after meals, sometimes see what the pattern is like. Again, the idea we're accumulating data so we can make a better decision for the patient and help them to understand what's going on. It's not just for us, it's for them. We have them watch their weight. We teach them about exercise and diet. So there's a lot of things that we can intervene in this little golden window that we have. We've diagnosed them with pre-diabetes, but they're not, frankly, diabetics yet. To your point, there's a lot of emotional stuff that happens right then, because chances are they come from a family where they have diabetics. Chances are they know diabetics in their peer group or their friends. And so they're like, oh, now I'm going to be like Uncle Joe who lost his foot because he didn't take care of his diabetes. And, they just start spinning and going down that road. So that's where a good support system at home is important. But if they don't have that at home, or even on top of that, we can offer them mental resources, mental health resources, and help them to try to process this, go through the stages of grieving. Because if you're diagnosed with a chronic disease, you have to go through those, denial, anger, bargaining, depression, acceptance, to get to a spot where, okay, I have diabetes now, and now I need to learn how to deal with it. So I think that's that little space in there where we can really get to people and help them understand. Now I'll sit down with them and say, because almost always they say, well, am I going to have to go on insulin? Like, well, maybe not today. So there's a lot of things that we can do before we get to that, and talk about reversal. And I tell people, look, you fit the diagnosis for diabetes or pre-diabetes, but this isn't necessarily a one-way street. Now, if you have a strong family history, chances are yes, but we can delay that. We can either reverse it, or we can really flatten that mountain that I talked about, flatten it into a little hill, and then we can work our way up the hill and find our way that way to have people be able to help themselves. And it's about also setting goals, right? You just don't want to let them loose without any idea of what they're supposed to do. So setting goals, I want you to exercise 20 minutes a day per, 3 days a week, right? And write those down and bring those back in next time you come and see me, and let me see how you did.
Those SMART goals that we usually
Right.
try to, yes.
Exactly. Attainable. Yeah, I'm not going to come up with all the acronyms right now, but yeah, there you set them. There's actually metrics around them. There's numbers set to them, not just, try to exercise more. That doesn't work. You have to give them numbers and something to aim for.
Right. And you touched upon the continuous glucose monitoring sensor. So early on in the disease onset, even for those people who have pre-diabetes. So yes, we do have studies now showing that continuous glucose monitoring sensor is, one of the behavioral modification strategies that is going to help even people who have pre-diabetes with, going back in time and maybe reversing this insulin resistance that is going on in their body. What is your take on it? Because there are a lot of people, even without pre-diabetes, just going for CGMs. So I mean, when is it that that line that we need to define, but also like how is it that is going to help us?
Yeah, great question. For me, I would always try to tailor that to my patient. There are some patients who just aren't going to wear those things all the time. And, you know, I'll be a little prejudicial here. It's older men, right? A lot of times that they're like, I don't need that. I don't want that. I think as, now even folks middle age, my age, are so much more tech savvy. And then especially with the millennials and the Gen Zs coming in now, they're all about that, right? They live on their phones. They want to see this kind of thing. And so if they're really motivated and really interested, I will start a CGM early. Sometimes it's a bit of an insurance battle, as you know very well, but a lot of times we can, get that covered for them. And if we can, then it's wonderful. And then they're on their phones all the time and they get, bing, there's an alert. Uh-oh, your blood sugar is a little too high, right? What are you going to do about that? Or at least identify patterns. Oh man, and when I went to, Olive Garden, man, that really shot my blood sugar up, So learning from experience and how that affects your blood sugar is all part of the acceptance part of the diagnosis, accepting here's what I am now and here's what I have to do. And sometimes it's harder than others, but I think using a CGM can really be helpful. Now, if you have even better, if you have a CGM that hooks into an app on your phone that can do a couple of things, your app can maybe talk to your doctor's EHR system, electronic health record system, or it gives you alerts, or it compiles the data and shows you trends. Those apps can be really, really helpful to do that. And then on top of that, say, I notice a pattern that your blood sugars are always a little high about 6 p.m. Why do you think that is? Or maybe that's something you bring to your provider. Those kind of pattern recognitions. And then we get into the world of AI and all the AI tools that we can use to really analyze the data. We keep talking about we want a lot of data. Well, then what do we do with it? The doctors don't have time to, wade through piles and piles of numbers. We need some way to in collaboration with these technology companies and others, how can we use AI in a smart way to help us, compile the data so that we can make really good medical decisions for these folks?
Right. You touched upon just now that you talked about, like, middle-aged men having this reluctance in
Right.
facing the CGM and using technology. But also there's a cultural aspect to, the
Absolutely.
care provider being different, and the cultural acceptance of the disease itself is there. So what are your thoughts on those?
It's huge. And, I think if you look at different cultures and different folks around the world and how we eat differently, how we exercise differently, how our cultures are different around familial tendencies to all play a sick role, or who plays the sick role, or and who does all the cooking and who is expected to manage all of this. It has huge implications. And I think we're just on the cusp of understanding that. And here in Minneapolis, we have an enormous Somali population and a lot of folks from Southeast Asia, the Hmong, the Karen populations. They eat differently than I do, right? And if I'm going to be a doctor who's having this patient come in, they don't even speak my language. I need an interpreter, and then I'm going to try to talk to them about diet. I may have no understanding of what they eat on a regular basis. So it's incumbent upon me to learn that, number one. And number two, speak in a culturally sensitive way to those folks. And I can't just tell them, hey, you might want to stop eating, don't eat so much rice. To some people, that's like half of their diet, right? So, I mean, you have to do it in a way that makes sense to them and isn't saying, oh, your culture is bad because you eat all of this X carb. And it's funny because you could look at different cultures and everybody has their carb of choice, and they're all pretty detrimental to health, whether it's pasta or potatoes or rice or tortillas, you name it, it's a carb. Not that you can't have any of that, but you have to be aware of what those folks eat. Now, when you're talking about technology, and apps, boy, that's hard. I mean, if I have someone who is here just recently from Somalia, they don't speak English, they can navigate a phone kind of, but if I have an app that's only in English, I mean, obviously that's not going to help them at all. But then again, we can't make an app with 230 languages either. So what do we do about that? And I don't have a good answer for that. I think that there are ways that AI could probably help with that in time as AI develops and gets smarter to help us with that sort of thing. But I think in the early parts of this, and not early, we're way behind the reality of this cultural issue. We're way behind it. But if we try to start making inroads into it, the first step is recognizing, wow, I need to think about this patient as a person that is different than I am. And I don't want to look like I'm preaching to them, telling them, you are bad. And sometimes that might be how it comes off to them. You have diabetes. Oh my gosh, I'm sick. I'm going to die. No, hold on. Let's talk about this. And this is what it means. And it takes, it's a challenge to educate sometimes for folks in different cultures that may not even know what diabetes means. I mean, I think the vast amount of Americans know what diabetes means, or at least they've heard of it, but they might not understand what that word diabetes means. And so you have to break it down. Blood sugars are too high. What does that mean? Oh, well, the food you eat, your body's not taking, you're not handling it. Insulin resistance. Wow, you can get way down a road where they're just going to glaze over and say, I don't understand what you're saying. The right translator in there, and what we had at one of the clinics I used to work at, we had folks that that were from the community working at our clinic. And boy, that was great, because then they could talk to them like they're their neighbors, not like someone who looks like me. So, I mean, that's not always practical, but when you talk about different things that we can try to do to get ahead of this, those are kind of the things that I think of. Now, obviously, there are some languages that that work has been done in Spanish and French and some of the European languages, but there are so many others that we don't have inroads into to try to help folks.
Right, right. I think, like you mentioned, having a non-judgmental way of handling
Right,
everybody is, firstly very important. It is very difficult for everybody to relate to the doctor, but then again, one size doesn't fit all.
right,
Approach is also needed. Like, so if we understand that the cultural background is different, and we inculcate our medical practice and our dietary advice, and whatever advice we have to give them according to their culture, it really makes a big difference in their lives as well, like you mentioned,
right, right.
Dr. Smith.